Hello, my name is Yvonne Chun, a stroke physician from Edinburgh, United Kingdom. It is my pleasure to interview Dr. Jingyi Liu, a neurologist and a PhD candidate, and Professor Liping Liu, Professor of Neurology and Stroke from Tiantan Hospital in Beijing, China. Dr. Liu, could you summarize the TRAIGE trial and the findings for us?
Sure. So the TRAIGE trial is a randomized controlled clinical trial in patients with acute spontaneous intracerebral hemorrhage who present within 6 hours of stroke onset. So there are about 2 million ICH patients annually worldwide, but effective treatment is still lacking. And so previous trials have shown that hemostatic therapies may reduce hematoma growth, which is a known factor for mortality and poor outcome. And so we performed this trial with a selective inclusion of high-risk intracerebral hemorrhage patients, meaning that patients had either the CT angiography spot sign, CT blend sign, or black hole sign on their baseline imaging. And these are all indicative of a higher risk of hematoma expansion. And patients were randomized 1-to-1 to receive either placebo or tranexamic acid within 8 hours of onset. The primary endpoint of the trial was hematoma growth at 24 hours. This was defined as a growth of either 33% or an absolute growth of 6 mils. So the results of the TRAIGE trial did not show a benefit of reducing hematoma expansion, but there was a trend of lowering the risk of mortality.
Thank you. Could you perhaps tell us a little bit more about the spot sign, the blend sign, and the black hole sign for those of us who are less familiar with these imaging findings?
Right. So we chose these 3 imaging markers in the TRAIGE trial as indication of patients at a higher risk of hematoma growth. So the spot sign is a focus of contrast enhancement of spot-like appearance within the hematoma, and this is seen on the CT angiography. This sign was also used in the STOP-AUTH trial and also in the TEACH-2 trial. However, the spot sign has a disadvantage of being difficult to recruit patients, as CT angiography is not as routinely used as non-contrast CT, and it will require a longer scanning time, which could delay treatment. So the blend sign and black hole sign, these are 2 new heterogeneous densities on non-contrast CT, and they have been identified as independent predictors of hematoma expansion. And so to mitigate slow enrollment and to better include all high-risk patients, we expanded our inclusion to include all 3 signs.
I read in your trial publication that the imaging was reported by the central radiologist, not the central radiologist, the corresponding center. Was there a central adjudicating process, or did you get an idea of the inter-rater variability?
Well, sure. Each center had designated senior radiologists, and they had received unified training and assessment before the trial started. Excellent inter-observer agreement was obtained for all imaging markers, and in situations of disagreement, the imaging would be brought up by a consult by a third radiologist.
Thank you. I saw that there were more male than female in your study sample. I think over 70% were men in your study. Could you comment on the representativeness of your study sample in relation to the intracerebral hemorrhage population in China?
Well, that is an interesting question. So indeed, the percentage of male patients, which is roughly around 72%, is slightly higher than the male incidence rate found in observational studies. However, considering the relatively small size of the TRAIGE trial, I would consider this within error range and also in accordance to the higher incidence rate of ICH in male patients in China. Furthermore, some studies have shown a higher percentage of male patients with black hole sign positive and blend sign positive. So that could influence the population as well.
Thanks. In light of the results of your TRAIGE trial and the TEACH-2 trial results, which were presented 2 years ago here at ESOC, where do you think TRAIGE trial will lead us in the future of tranexamic acid in intracerebral hemorrhage?
Well, the primary results of recent trials focused on chemotherapy therapy in ICH patients have not been ideal. However, some results from our subgroup analysis may provide opportunities for future trials. For example, in the TRAIGE trial, when we stratified by treatment time, there was a trend of effect in patients who were treated within 4.5 hours comparing to those who were treated later on. And when we look at baseline hematoma volume, patients with a baseline volume of greater than 45 mils seem to benefit more from treatment. And similar findings have been reported in the TEACH-2 trial and also the STOP-OS trial. And so it is fair to postulate that larger studies with patients with a more moderate sized hematoma and also with an earlier treatment window could be the target population for future studies.
Thank you very much. And finally, could you tell us where your trial has been published, just for the audience?
Okay. So the main results of the TRAIGE trial has been published in Stroke and Vascular Neurology Journal, alongside with a meta-analysis of 4 recent RCTs on hemostatic therapies. And we are also working on further analysis of the population and some collaboration possibly to look forward to.
Congratulations on your study, Dr. Liu and Professor Liu, and thank you very much for the interview.
Thank you.
Thank you.